I'm gonna turn it over to Russ and kick us off with our first question. So thank you, Russ, for joining us. Why don't we give them some context and some things that you were sharing with our Up Next CFO group and your thoughts around seeing Medicare Advantage as a threat to healthcare? Let's just kick off with you sharing to this group what you shared with our Up Next group.
Sure. Appreciate being here, and thanks for everybody joining the call. Um, what we told the group was it kind of stemmed from a 5 and 10 year planning session that we went through about a year or so ago. Lots of headwinds everybody's facing. This is just one of several that we have to account for. I had some other colleagues in the state complete a similar review and analysis, and they shared what they were concerned about, what they were seeing, and the trends and the numbers in Medicare and especially Medicare Advantage. So much so we've had a few systems terminate some Medicare Advantage contracts because of what they feel is coming down the tracks. Our population is moving much more to Medicare base and a full governmental payer mix. You know the statistics: 11,000 people are turning 65 every day. Medicare spending is projected to double in the next 10 years. In our own payer mix, we're seeing a decline of the commercial and slow conversion again to all governmental payers. I've been here 25 years. When I started here, the cross subsidy of Medicare or commercial rates to Medicare was about 120, 130% of Medicare. And now our commercial rates have to be about 225 to 250% of Medicare to keep us at that same level. And again, when I started here, the 65 and older were about 10% of the population, and now it's about 20%. And so we know there's not a lot of money in the federal government. You see what's happening. The enrollment continues to accelerate. The workers per beneficiary will continue to decline. I've heard talks about the Part A, either the Medicare tax has to go up or the decrease in spending by about 15% over to keep the Medicare Part A trust fund solvent over the next 20 years. And that's not Part D and Part B. They're financed by the Medical Insurance Trust Fund, where in 22, 13% of all taxes went to cover the Part B and Part D. And by 2030, over 22% of all taxes the federal government takes in is going to be used to cover those programs, and that's outside of Medicaid. And so the government likes Medicare Advantage. We all know that. We've seen growth in Medicare Advantage here. In my markets in 2008, we had less than 10% Medicare Advantage. By 2015, it was 20%, and now we're right at 50%. And we limit the contracts that we have. We only have 4. We don't take all comers. We try to manage it, but we've still seen that growth, and it's going to continue. If you look at why it's grown, I mean, one of my board members said, "Well, let's just get out of the Medicare Advantage business," and it's not that easy. Consumers love it. You've got 94% they're satisfied with their coverage. It's been pretty profitable for the insurance company up to the last couple of years, where they've had a couple of rate decreases. But you saw almost an 80% increase from 18 to 23 in the number of plans across the country. Everybody knows that Medicare Advantage, you get additional benefits, dental, vision, meals. But it's more about the cost for the patient. When we kind of dove into it, 40% of those around here that are retired, Social Security accounts for half of their income. And another 20% of those are retired. Social Security is 75% of their income. And if you have just Medicare Indemnity, that cost sharing takes up about 30% of that Social Security income. So Medicare Advantage is only feasible for a lot of folks on to be able to live. So it's not going away. So we looked at our current volumes, our payer mix, we did an analysis, and we had different levels of performance in the Medicare Advantage space. Overall, we saw a payment level of about 88% of Medicare being achieved. So our Medicare Advantages were paying us 88% of what we were getting from Medicare Indemnity. Some were better, some were worse. It ranged from 85 to 95%. We started to look out and project population shifts, a model that went 10 years out. The under 65, our under 65 is declining, especially in the inpatient side. Outpatient may increase, but a lot slower rate. The 65 to 75 cohort is inpatient, outpatient are going up at a pretty good clip. But where we feel like we're going to see a lot of increases, that over 75 group, they use services at a lot higher rate, and that's going to be the piece of the population that's growing the biggest here. And we feel like the inpatient and outpatient are going to go up about 50%. And so then you couple that with a migration that you expect from Medicare to Medicare Advantage. And what we found based on our analysis is if we don't change anything, just by the population shifting and where the business goes, we would go from a pretty good positive margin to a negative margin at the end of those 10 years. And it wasn't just the erosion of the payer mix and the lower yield of Medicare Advantage. Administrative costs in the Medicare Advantage are a lot worse. Denials cost us $40 more per denial to work than an indemnity denial. The physician subsidy, all of us are employing more physicians. The Medicare conversion factor is only going up 10%, or has gone down 10% since 2017. My 25 years, it's only grown 9%. So we rarely see independent doctors anymore. So our subsidy continues to grow for physicians year over year. And we didn't even factor in some of the other possibilities. Even with this change, the way the DISH percentage is calculated, we could lose 340B just by the population changing out, because it's Medicare day, SSI days over total Medicare days, and then Medicaid over total patient days. And as those two denominators grow, we have one of our hospitals that's eligible for 340B now. We don't think would be in about 10 years, and that's specialty pharmacy impact in addition to just regular hospital pharmacy impact.
Right. So, and we talked about 340B a little bit when we were at the Up Next CFO exchange. So all of those things combined, it comes up quite a storm for not only our CFOs to kind of grapple with, but any of our executives looking at, what's kind of facing them head on. So what are some strategies, and surely we don't have enough time to cover them all here today, but what are some strategies? You mentioned shifting your payer mix a little bit, but what are some strategies that you're looking at to kind of relieve what's going on with this pressure cooker that is just kind of building up? And, you mentioned the forecasting that you do, and you can see down the line what's coming at you. So what are you doing in some planning regards to kind of alleviate that pressure?
There's a few things. Contracts obviously are like everyone, some of the others, contracts with our Medicare Advantage. We started discussions with 2 of our 4 plans, the ones that have the highest administrative burden, the lowest payment yield, renegotiating those contracts. The goal for us at the end of the day is to have 2 or 3 plans in our system that are as close to the Medicare indemnity yields as we can get, and that limit our administrative burden and the cost there. And that's both for the hospitals and for our physician clinics. We've got a list of about 30 items that we're trying to address within the contracts. Just some of those prior authorization. Everybody's dealing with prior authorization. We've got authorizations for not a procedure, but supplies, drugs that are integral to a procedure. We don't have procedure like authorizations for procedure families. It's individual CPT codes, or we've addressed it with some of our Medicare Advantage plans, but not all of them. And these 2 we're attacking. Sepsis 3 versus 2. We had a lot of talk about that at the Up Next CFO exchange. All these Medicare Advantage plans have gone to adopt sepsis 3 as a diagnosis, and it doesn't seem like much, but it's got a lot of teeth. So sepsis 3 is you have to have basically almost organ failure or close to dying. It's severe sepsis, and so they've eliminated sepsis as a diagnosis. And part of the problem of that is that when you eliminate sepsis as a diagnosis, you're still treating sepsis. But the case is being, if it's not severe sepsis, is being delegated into different DRG, UTI, cellulitis. That's a lot lower payment and cost, because they're still using the Medicare indemnity weights and payment mechanisms, and Medicare indemnity recognizes sepsis too. So all of that amounts is to a pure payment cut. There's no patient quality, patient safety. There's no fraud and abuse in it. It's just a pure cut. So if we don't make progress with those, we plan to terminate them and move patients to plans with more favorable terms. But I can tell you, I've had CEOs of a couple plans tell me that they'll never get to 100%. We'll get you close, but there's no way we're ever going to get you to 100% indemnity yield. So that's telling. We're also focusing on growth. I think growth when for a long time when I first started my career meant to get bigger, right? More revenue, and it's really changed a lot. I think now in certain times in certain areas it means get stronger, support financial sustainability, access, enterprise vision. So we're looking at things that we don't do well and things that may not be profitable, where we can either partner, make changes, invest, or divest. And so like plastic surgery, we've got plastic surgeries, some that are still being done in the hospitals. We're moving all those to the ASCs where it's a lot lower cost. Behavioral health and home health, things that are very important to us, especially for Soul Community Hospital in one of our markets. But we don't do it well financially. We're looking for partners that have the expertise in running behavioral health, running home health, so that maybe we can do it a little bit better and get a little bit stronger. And then maybe even divesting in some. We have a nursing home, and again, it's something that we don't make money in. We don't do well, and then maybe we want to keep it in our service area, but maybe a partner or give it to somebody that specializes in that space and can do it better. We're looking at accessing care management journey. We're trying to do everything we can to become an access company that allows consumers to easily enter and travel through our system without friction. So a lot of work with systemness, medical group integration, referral management. I was really surprised how many referrals, even though it's not a ton, but how many referrals leave our system and why they're leaving our system for things that we do. We're also one of 30 health systems that is involved in an IHI age-friendly health system cohort. And the goal is to implement age-friendly care across the clinics and across our health system to ensure optimal health care and efficient health care for our older adults. So we're in the middle of that. And then there's efficiency, right? It's the never-ending items that we all work on for years. Cost efficiencies, labor, supplies, IT, revenue cycle, length of stay. I talked a little bit about systemness. We have supplies and drugs. We're going through a big overhaul in both of those areas across our system, where even small things like IV starts, where we've got different hospitals buying different things, or maybe at the same thing at different prices to lock that down. Revenue cycle pressures are continual challenges. Everybody is working on how to get paid correctly for the medically necessary care they provide. Everybody on the call probably has a team is focused on that same thing. But we're also looking at how we can integrate technology, AI, into our system to help with that efficiency. We put something in place, and I'll tell everybody it's wonderful. It's called Assist IQ. We were the first hospital in the U.S. to put it in place integrated with Epic. It's an AI technology that recognizes supplies and implants in the OR. It's not barcode scanning. It's a supply packaging. You put that on a tray, and the system recognizes it, documents it in Epic in a single snapshot. After 1.5 months of using it in 1,300 cases, we saw a 90% drop in inventory errors. We had pulled off 1,000 inactive items and took them off of our pick lists. And so what we're seeing with it, the analytics that come along with it are pretty robust. It puts things you can see cost clusters on every case. And so like a prostate biopsy case, we identified where we had lack of documentation on a high-cost rental probe because there were two distinct cost clusters, and the system analyzed it for us. So from a revenue integrity, from an inventory, from even a less labor cost, this thing's been pretty amazing, and we're very early on with it. We're putting it in our cath lab. We're going to look at the ED next.
Mm.
So it's things like that where we've got to leverage and keep pushing. And then the last thing I just mentioned, the length of stay, avoidable hospital days. We had a project on our flagship where we've reduced like 0.8 of a day overall in the past 18 months. And some of that after COVID kind of crept back. And if you're not focused on it, it's it's the old you never stay the same. You get worse or get better, and we got worse.
Yeah, I think that kind of strategy is one that we talked about. I believe it was last year at our CFO exchange. And it was just that idea of going back to basics when you think about, trying to improve growth or trying to improve your bottom line, doing what you do well and making sure that everyone is operating optimally across the system is where you can find those pockets of, oh, well, we weren't paying attention as much to length of stay over these past couple of months. And here's the data to show how that's impacting us. I also like the AI tool that you're using. I think that's a really cool way to, we talk about applicable real-time AI uses that aren't just machine learning types, but real AI use cases. And I think thinking outside the box with those sorts of tools is going to be imperative to health systems moving forward, just to try and combat what's going on.
We also are trying to do that with our employers. So, the employers are important to us. We're trying to make them sticky with us. It's very symbiotic. We know we're an expense on their financial statement.
Right.
And so we've implemented, it's called Title Care, which is, we've actually put it in our hospital. And we've got a lot of employers that want on-site clinics, but they can't afford it. They don't have enough volume to justify the cost. We don't have the resources to put nurse practitioners in every clinic. And so this Title Care, it's if I'm not feeling well, I can go down to a room in our hospital, and it has an iPad and it's a virtual visit, but it also has technology with it that allows the practitioner to listen to my heart and lungs, look at my ear canal, my throat, blood pressure, blood oxygen. And so and we have got a bunker with nurse practitioners that are there, and the overflow goes to our urgent care centers, but it allows a real an on-site employer clinic at a fraction of the cost for those employers. And so we've got over a dozen employers, and we're actually looking at to put it in our school systems. It's pretty neat technology and allows us to be a lot more efficient and cover a lot more with the limited provider resources that we have.
Russ, Abby, I'm sorry for interrupting, but Russ, I think your voice may be muffled because you're speaking through your phone. So
Okay.
if somehow you can speak up a little more, I think it's kind of very soft and muted. So just
I'm sorry.
That's okay. That's okay.
I hope this is better. Sorry about that.
That is much better.
Using the speakerphone. Sorry.
No, that's okay. But actually, we have about 10 minutes left in the call. So I want to look forward to this kind of future predicting that we were talking about. And we were actually just talking about in a pre-call that we had. It's anticipating the regulatory changes that are coming. I don't think it's any secret to anyone on the call that changes are coming, and they're coming fast, and they're a little unpredictable at the moment. But how are you anticipating and planning for and having conversations with changes that are coming from the new administration that are going to impact for better or for worse? There are different ways of looking at it, but how are you planning, and what are conversations you're having, within your system and with your local, federal, and state legislators about Medicare Advantage's impact on healthcare?
So it's a good question. We're in our budget season, so our fiscal year ends in May, so we're knee deep in the budget season, and we've modeled out changes within that. On the federal side, there's a lot of things to be concerned about. Everybody is. Representative Brett Guthrie, who chairs the House Energy and Commerce Committee, actually is our rep in our district, and that's the group that's charged with will be charged with finding about 880 billion cuts, where Medicaid would probably receive the lion's share. Nobody knows where the cuts are going to occur, but everybody's making their own cases to their legislators about what they don't want touched. We're actually hearing that the administration is pushing that 880 billion is not enough, that they're actually pushing for it to be a higher number. We'll see what happens. Medicaid is not a rich state. Medicaid covers a third of our population. Federal government funds 75% of our $20 billion annual budget. We have the fifth highest FMAP, and the different 71% of the federal shares are traditional Medicaid. CHIP is 80%, and the expansion population is 90%. So they pay 90 cents on every dollar. We looked at the different, trying to model the impacts of different scenarios. One that I think that came out this week, HFMA kind of focused on was the expansion match, that 90%, moving that to where it would be 71% in Kentucky, and making that more of a traditional match. That's starting to get legs. We think at $600 billion there. There's a lot of other things that are been proposed. Eliminating the expansion population, eliminating provider taxes to some level. Those could be a 19% cut. We have high directed payments here, significant directed payments. So we have state supplemental payments that are based on the commercial rate for our population. They've helped support the health system in Kentucky. Those would be, if they eliminated directed payments, it would be a 28% cut here. And that would be about $100 million for my health system annually, which would be significant and would require more than just efficiencies to address. Per capita cap impacts are not known. Eliminating the FMAP floor is another one where the FMAP has a floor of 50%. So if the federal government would only put in 30% based on the calculation, it gets bumped up to 50%. That wouldn't have any impact on Kentucky because we're above that floor. So Kentucky would have to use either more state dollars or cut services eligibility or provider rates. So we're factoring in some of those that we think are most likely. We think that they may repeal the Biden eligibility rule. The work requirement, they've already passed that in Kentucky. We feel like that's going to go in. And then possibly that traditional match for the expansion population. On 340B, we're hearing early versions of a draft budget bill that have HRSA moving to CMS that will require entities to report on the use of savings to ensure program is used to benefit the uninsured and low-income populations. So how that would impact us with 340B is kind of unknown, but that's something to watch. We don't hold out a lot of hope for the historical healthcare extenders to continue. The Medicare dependent, low volumes, doc rates aren't going to get better. We don't think that we're watching the nonprofit status. We don't think that that's something that will come to fruition. We think a lot of smaller things could happen in reconciliation, Medicare bad debt elimination, eliminating maybe the inpatient only list. On the commercial side, you've got the ACA subsidy cliff, where if Congress does nothing, those premium subsidies will expire at the end of the year. That's about $330 billion over 10 years. All premiums will go up. Uninsured would increase if that happens. And it's more than just the individual. We've had a lot of smaller employers that have been pushing the ICRAs, the individual contributions to the health reimbursement accounts. It's where a small employer will kind of level funds a premium that goes out to their employees, and they go out to the exchange and they pick their own plan. On the state level, we've got certificate of need that could have big changes if that goes away or gets changed. We've got a Medicaid oversight board that has been passed, which will limit Medicaid's ability to make changes on waivers and different things. So a lot of potentially negative. Again, it's been an interesting budgeting year. One thing we were talking about, Abby and I were talking about at the CFO Up Next exchange. Somebody asked a question, how close are you with your state and federal legislators? How many know them? How many have had conversation with them in the last 6 months? And there were very few hands that went up. And we think it's real important. We have very significant relationships with our state and federal legislators, and it's not just one of us, not just our legislative person. It's our CEO, our CFO, our board chair, because it's we're the biggest employers in their districts, and we feel like we need to have they need to understand how it would impact us.
Definitely. And one of our, to that same regard, one of our CNOs, Jean Putnam, who is the CNO at Baptist Health in South Florida, she, this is a big passion of hers. And she shared, when you meet with them, it's putting it in the verbiage of your constituents believe, or this will impact your constituents because of X, Y, and Z. And they ultimately want to get revoted at the end of the year, right? So it's framing it in that way to help them understand the impact that some of these decisions will not only have, on their constituents, but as a whole to healthcare and what that can mean for them. So, well, we're coming up on time. I want to do a last call. Thank you, Russ, so much for this. This is really important. And I know it's facing a lot of our executives looking down at it this year. If there are any last minute questions, put them in the chat. We thank you all for joining us today.
I'm willing to share anything that anybody is interested in that I shared on the call. Not a problem.
Great. Well, if you have any questions for Russ, feel free to reach out to me. I'm happy to connect you with him directly. And Julie makes a great point. We do have a few last minute spots that came open at our Up Next CFO Exchange. We're talking about this in one of our dedicated roundtables, actually. So if we have any of our CFOs on the call that maybe their plans have changed last minute, or any of our other executives that would like to connect us with their CFO to have important conversations like these, reach out to Julie or myself. We can make sure that that spot is reserved for them directly. So we thank you all for joining us today, and we look forward to seeing you at the next community call. Thank you, Russ.
Thank you.